Hi, everybody, and welcome to this special edition of MacroPro and Friends. We are delighted to bring to you again our 12 CEUs to Christmas. We have lots of great programming coming up for you, so I certainly hope that you look at our website for every single day, the different topics that we have to cover. I am joined today by Wendy Stevens. Hi, Wendy, how are you?
Hi, Diane. I'm doing well. How are you today?
I am great. I'm getting into the holiday spirit. My little reindeer's here. Just having a lot of fun.
It's awesome.
And how about you? Are you enjoying the holiday season?
Yeah, it starts to get busy right after Thanksgiving. And, that's when I put up my holiday decorations. I'm going to throw that over to you, Diane, to talk about when you put your holiday decorations up.
Well, while I'm doing that, let's ask everybody, when do you put your holiday decorations up? Put it into the question box so we can see what's going on. I typically always put it on the weekend after Thanksgiving, but this year I was having an early party, so I got decked the halls a little bit earlier than that, so it was kind of fun. So, oh, look here, we already got people saying December 1st, right after Thanksgiving, the day after Thanksgiving. Nicole, Wendy, Emily, Lori is the weekend after, shortly after Thanksgiving. Jesus, David says, when my wife yells at me, it makes me do it. Ah, that's excellent, David. All right, I'm gonna do a little bit of, what's that?
I see one shortly before Thanksgiving.
Wow. That's kind of cool to see. Well, go ahead and continue giving us your answers. I'm going to do a little housekeeping. And the housekeeping goes like this. Today's webinar is worth 1 CEU. You must be logged on to your very own. Go to webinar link so that your name will be on the certificate. You should get that about an hour after the presentation. Once, if you, for some reason you don't get that, I can help you out for the first 30 days, but after that I cannot. So make sure that you ask me immediately if you need any assistance. There are handouts for today's program, so please make sure that you download those. There's lots of handouts today, 5 of them. And then if you have any questions, you can ask them in the control console where you are sharing with us your decorating history. So that's the same exact place that you'd be going to. And then there'll be an encore presentation of this on the MacroPro YouTube channel. So Wendy, can you share a little bit more of what people are saying, and then we'll get started with our presentation.
Absolutely. I have one person who it reads, oh, it's Adrienne Lewis. She indicated that she starts in October because she has so much stuff to put up. I hear that. I completely hear you, Adrienne. Takes forever, it feels like. Yeah, I
Yes,
put on the Hallmark channel and I do just like you, Adrienne. I start putting it up, but mine's after Thanksgiving. Most of them, Diane, are before Thanksgiving, after Thanksgiving, and whenever I have free time. It sounds like everybody's getting in the nice Christmas and holiday spirit.
Yes, absolutely. Okay, Wendy, I'm going to let you talk with Janice and we can learn about today's programming.
Absolutely. I have with me today Janice Harris with MEDLink, and Janice has brought to us a wonderful speaker who's going to be talking about CRPS, and I've heard this presentation before and I really learned a lot. So Janice, how are you doing? Before you tell us about the doctor, if you could let me know, are you ready for the holiday?
I'm not yet, but I will get started soon.
I know how that feels too, huh?
I'm stressing out, but I'm happy to be here.
Oh, wonderful. Well, welcome. If you would please introduce Dr. Teicheira, we would certainly appreciate that, and then we can go ahead and get started.
Great. Dr. Teicheira, I'm so excited to have him speak to you today. The one thing I did do to get ready for Christmas is we changed the theme. Instead of the slide being Soaring, it's a Christmas theme. We have all kinds of Christmas backgrounds. So at least we're current, right? Here we go. But Dr. David Teicheira, I'd love to tell you about him. He's been with MEDLink. Wow, but we've been working with you for about 8 years now, and he's been a QME since beginning of all this, all of our systems are go. And the background about Doctor is that he's an overachiever. He's board certified in anesthesiology, internal medicine, and he was also board certified in pain medicine. He received his medical degree from University of Southern California and his fellowship there. He was in private treating practice in Sacramento for all those medical specialties from 2000 to 2019. But now he's just doing mostly QMEs and AMEs. The pain medicine specialty is not in play, but it is with anesthesiology. So I want you to be sure that you understand that. Don't be scared. He's a very reasonable doctor. Anyway, the thing is that doctor has been doing these QMEs for a while and AMEs, and his background allows him to do cardiology, internal medicine, pain, and all of the specialties that go along with chronic regional pain syndrome when that occurs as well. Dr. sees QMEs and AMEs in our Oakland, Sacramento, San Jose, and now Santa Rosa offices. So if you need any of those locations, it's available. And one last thing about Dr. Teicheira is that his wife Teresa, they are avid tango dancers. So after this presentation, I know every time I see you in the evening, you and Teresa are going off doing the tango. So so without further ado, let me get you started with Doctor. Let me get on to the slide and I will undo me. And here we go. Take it away.
Okay, thank you. Can you all hear me? I'm assuming.
Yes, we, doctor.
That's great. So yeah, I ended up doing, after internal medicine anesthesiology, I did a fellowship in pain management and medicine at UC Davis. And I had a pain medicine practice for over 25 years. So I had a lot of exposure to complex regional pain syndrome as a physician that was evaluating and treating these patients, and then continuing on as a QME evaluator. So what I'd like to do is share some of the things that I've learned that I think is important for all of us in the medical legal system here, to give us some background to make your jobs a little easier through understanding what's going on with this syndrome, because typically it has been very difficult to diagnose because it can appear to be so many other things. And it's also, from the patient's point of view, it is a pain diagnosis that carries kind of more misery than any other particular one that I've ever dealt with, for a lot of reasons. But also it's hard also on the patient's family, it's difficult for the caregivers, the physicians and nurses and everybody else that are helping deal with this, and also for the medical legal community. Often just because it's so weird, it's hard to understand. So what we're trying to do here is to make it a much more approachable for you all, so that instead of just getting hit with this diagnosis and feeling kind of overwhelmed, or I don't want anything to do with it, it's more approachable. And I think it is a very approachable diagnosis after I've shared what I've picked up over the years. So next slide, please. So there's a lot of information here. I don't expect anybody to pick up all of it, but I'm going to do my best to kind of give it a bit of plant some seeds. Now, first of all, by definition, CRPS is a disease of injured people. If there's no injury, there is no CRPS. Whatever's going on is something else. If there's no injury that you can tag it to. And that's very important, as we'll see a little bit further, because sometimes CRPS is a diagnosis of frustration. It has a couple of, it sort of looks like that to me, therefore I'm going to give it that, and we'll send it off to that pain guy. So, but CRPS presents in a very strange ways. Now these two pictures are the same woman's foot. And the one on the left is probably at her home since there's a parquet floor. And you can see it's red, it's swollen. If I tried to touch that, she probably wouldn't let me. She'd jerk back because people with CRPS can't stand to be touched because touch, just light touch, becomes excruciatingly painful. Now, the picture on the right is the same lady at a different time. She still has CRPS. You can kind of imagine if this person had the left-sided picture at home, called her doctor, made an appointment, got seen in a few weeks, and she showed up with the right-sided picture, the doctor is going to wonder what's going on. What is she trying to pull? It's not going to be a very productive meeting. And that's part of the problems with this disease, is it can come and go this much in a short period of time and then go right back to being swollen and painful and red. Now, even the right-sided picture still hurts. If you try to touch her, that person's going to be hesitant to let you do it, but they might. CRPS is probably much more common than we think it is, but we only see that tip of the iceberg that's really bad. Looking back, about 7% of wrist fractures could be diagnosed with CRPS by somebody who knows the syndrome. Same is true with about 1 to 5% of any surgery. So what's happening with this is probably the beginnings of CRPS as part of the natural healing process that happens with any injury, but something goes wrong and it snowballs out of control some of the time. And that's when we really see it. The other problem is this swelling and color and pain, those can be any number of a large list of things that we'll see in a couple of minutes. So it makes the diagnosis just hard from that point of view, because a lot of things can look like that left foot or the right foot. Next, please. So that's kind of what it looks like, and that's the basis of why it's frustrating. But let's go, but why does this end up happening? Why has this turned out to be such a terrible diagnosis? So an injury occurs, and then in some people, those changes that are probably part of the normal response to an injury get out of control. We don't know why, but it starts in the brain, and the brain starts sending out signals to the nerves, and the nerves start releasing little chemicals between them, and that causes some weird behavior to happen in the nervous system. Nerves are supposed to be separate. So if I'm looking at my hand, this nerve could be light touch. This nerve could be pressure. This could be pain. This could be the sympathetic nervous system that controls our heart rate and sweating and making our blood vessels dilate bigger and contract to regulate blood flow. So all of these nerves are supposed to be and normally are separate. But when the CRPS starts, the chemicals between the nerves start unnaturally growing towards one another in the spinal cord. They start to cross connect, and then those cross connections become permanent. So now we have a light touch nerve and a pain nerve that used to be separate, but now they're cross connected, they're short circuited. That means light touch is now pain. And that's what we call allodynia, which is pain to a stimulation which shouldn't cause pain. It's just like if you just stroke your finger, that doesn't hurt. But if you had CRPS of that hand, it would be excruciating. There's a reason why the pain is weird. The nerves are now cross-connected, and that can be seen when in microscopic pictures of the nerves. The other thing that's kind of strange is the sympathetic nervous system, which, as I said, controls your heart rate. It makes my eyes dilate bigger. It controls blood flow. Those can be cross-connected too. And again, this has been demonstrated. So that when our sympathetic nerves are stimulated, the pain system is stimulated. So things that would normally cause your sympathetic nerves to be firing, like fear or danger or anger or a lot of emotions, cause the pain to get worse. It's a bunch of misconnections in the nervous system that never existed before. And these new arrangements start a cascade of events that cause the immune system to be activated and a chronic inflammation state. Inflammation is normal, it happens after injuries, but it's supposed to clear out the bad tissue and rebuild the good tissue. In CRPS, it's a constant wheel spinning of tear it down, build it up, tear it down, build it up, tear it down, build it up. That is not a good way to make tissue that's strong. So a lot of systems start to fail. The circulatory system, the nervous system, muscles get weak and incompetent, the skin gets thin, the bones get thin and damaged and break easily. And this all happens because of this cascade of events. Now, because all these weird things are happening to a human being, we start acting differently if we have this disease, and the behavioral system starts to malfunction. Next, please. So the important point here is that if we suspect that this is going on, we have to go a bit of extra distance, and we have to know that, number one, it's really happening to them. It's weird, but it is really happening if you make the diagnosis and it's accurate. Number two, an accurate diagnosis depends on the story they tell you. It's not just on what the doctor sees and the blood tests and the x-rays, because none of that's going to help. What's going to help is hearing the patient's side of the story, especially as we'll see in just a few minutes. And number three, it is really easy to dismiss these complaints as craziness. It doesn't make any sense, and it frustrates everybody, from the patient to the caregivers to the family and anybody that runs into it. It's so out of the ordinary. The other thing is, a lot of these patients are really reluctant to discuss their symptoms because they're so weird. They've tried to, but they get the same weird looks from people like what's going on, or that doesn't really happen. And they start to be disbelieved by people. When people start disbelieving you, normally you shut up and don't say much about what's going on with you. And that happens here. The pain involved is it's a burning pain, and it's a weird pain that's accompanied by, as I said, pain to light touch that doesn't make any sense to anybody. There are visible changes, as we have already discussed: temperature changes, color changes, swelling, changes in hair and nail growth, weird sweating, and stuff that most people have never experienced. So it's really hard to explain what's going on when the patient tries to do this, because it doesn't make sense to people. Then they develop adaptive behaviors that are mostly based on, don't touch me. I'm sorry, I've got something buzzing. So what they do to their family, if I have CRPS in this side of my body, I'm going to tell my family, you never ever come over here. You have to stand over there. You're not allowed to hug me. You're not allowed to touch me unless you ask my permission first. It becomes so weird a lot of times that people withdraw into a certain part of the house, Or I've had patients that change their whole sleep schedule so they are awake when their family is asleep so that they don't have to deal with all this stuff. And of course, this leads to all kinds of psych problems with anxiety and depression and whatnot. Next paragraph, please. Next page. Okay, the other weird thing about it is it can move, sort of. So if it starts on the foot, as we see in this first little picture, it's 100% of the time it will travel up the leg. In 70% of the time, it will go to a wholly different part of the body. And then in about 15% of the time, it'll show up in the opposite limb, just like a mirror image. Next, please. So here's the list of things that, a short list of things that CRPS can look like. It's a big list, and there's a lot of stuff. In order to diagnose this, you have to go through all these diseases to make sure that they don't have this first. Now, up until about the mid-1990s, the way it was diagnosed is the I know it when I see it method. What it is a small amount of doctors that have had run into this would get referred patients like this, and they'd say, it looks suspicious. Let's do some tests. Well, the only tests that they could do is bone scans, thermography, x-rays to look for bone destruction, and things like that, a few things. And that was typically what was used. And after the end, take all the evidence and come up with an opinion based on the I know it when I see it method. It wasn't accurate. It didn't result in good diagnoses, but that's what we had. It's a lot like the Jacobellis versus Ohio in the mid-1960s. This is something that went to the Supreme Court because it was a French movie with two people in a bathtub. And the justice involved with this finally said, I know it when I see it, and the movie involved in this case was not that, meaning pornography. So the old method was very subjective and not accurate. Next paragraph, or next slide, please. So in 1994, a lot of stuff happened. One of the things that happened is the International Association for the Study of Pain published this little book. They decided that they were going to try to classify pain and make the diagnosis a lot simpler for a lot of chronic pain conditions and a lot more accurate. So they had groups of experts from around the world in each one of these categories of chronic pain, and one of them was what we used to call reflex sympathetic dystrophy or causalgia. And you'll see these terms back and forth a bit. So this one group for the reflex sympathetic dystrophy, causalgia, CRPS, got together in Orlando, Florida. They put their heads together. They put all the studies up, and they chose everything that they thought the diagnosis of CRPS has in common. And they agreed that these are the things, if you look for it, you probably have that disease. And then they renamed RSD, reflex sympathetic dystrophy, to what we call it now, which is complex regional pain syndrome. They had two subcategories called 1 and 2. It is not necessary to understand that at all. It all looks the same. So what they had now was pretty simple. They had about 4 things in the diagnosis. Number 1, you have to have an initiating event. You got to have an injury. Number 2, the pain, there has to be pain that was disproportionate, out of proportion to the original injury. Number 3, there has to be some evidence at some point in time that there was swelling, color changes, temperature changes, excessive sweating, hair and nail growth changes in the affected part of the body. And number 4, it can't be anything else in that long list. They did a pretty good job, and we got better at diagnosing it, but there was still a lot of false positives. We were diagnosing too many things as CRPS. So that same group kept going together and testing all their theories and what was good diagnostic criteria, and published a lot of studies. And then 12 years later, they met again in Budapest, Hungary. Next slide, please. So in 2007, they met in Budapest, and they compared all their notes, and they compared all the diagnostic criteria, and they found that if they made the patient's complaints more important than what the doctor saw, they got very accurate. They got so accurate, they were up to 95%, which means you only had a 5% if you used these criteria exactly this way. It was only 5% of these would be wrong. 95% would be what we all agree we call CRPS. So the important thing that came out of the Budapest meeting is the Budapest criteria, which you'll probably run into, and the fact that it turns out the patient's complaints were more important than what the doctor saw. That same group met again in Valencia, Spain in 2019. They did not change the criteria because it made the specificity worse. So they kept it just as it was. That's about as good as we can do right now. They made the chart or the check sheet a lot easier for a doctor to use to diagnose it. And they added this very important new subcategory, CRPS with remission of some features. What this means is, if somebody was diagnosed with CRPS and the Budapest criteria were used, but they, right now, they don't have all those criteria and don't meet the criteria for CRPS today, but they did 3 years ago. That's CRPS with the remission of some features. This is important to us in work comp because that doesn't mean they're cured. It doesn't mean they never had it. All it means is they're getting a little better. That's important because I've seen at least 2 patients that I was called on to see after the fact that had CRPS that was very well documented, but a new expert was called in and said they don't meet criteria for CRPS, it's something else, which means that patient had to go, had to start over again, find a diagnosis, and then be treated for another diagnosis that wasn't CRPS. You can get better, but still have a problem. And that's what I want people to remember here. Just because you don't meet the criteria for CRPS, if you did before, you've still got it. You're just getting better, and that should be an outcome that we want. Next slide, please. This came out of the Valencia meeting also. It's a very easy checkbox for any physician who's willing to do a physical exam and pay attention to the patient. All you have to do is go through the boxes, check them off, and see what you're left with. If the patient reports a symptom out of one of these 4 categories, 3 out of these 4 categories, and the physician sees a sign out of 2 of these 4 categories, that's the diagnosis. Okay, next slide. All right, so that's how we do a diagnosis nowadays. If you get something other than that, it's going to be more difficult. So if we have a diagnosis, now we need to know, how do we reach maximum medical improvement? Well, the goal is functional restoration. It's not cure, because we don't have a cure. CRPS can fade over time, and in my experience, fading means decades. So not in a work comp timeline. So the goal is functional restoration. The approach needs to be multidisciplinary with concurrency, which means they have to overlap. It can't be, let's use up all this, then we'll ship it over to the psychologist and use up all that, and then we'll ship it over to physical therapy and use up all that. If I see a patient that I diagnose with CRPS, I will start a treatment plan. My goal is to try to minimize or lower what they're suffering a notch or two, so that they can see there's a little light at the end of the tunnel, and start developing a relationship with them and trust that we're actually doing something and we're getting somewhere with this. Once I've established that, then I'm going to bring a psychologist in to help me. I want to reinforce the concepts that we can't cure this, but we can manage it. And a lot of the burden is going to be on the patient changing their mind about how they're going to handle the pain, because it's going to be mostly with how they respond and move ahead with their lives. After we've got a good rapport between the physician and the psychologist with the patient, and the patient is ready to take charge of their life, then physical therapy is important in order to attack and provide for activities of daily living. This is kind of important because a lot of physical therapists really want to turn out people that can really go for it, like Olympic athletes. We're not trying to do that with CRPS. We are trying to let them cut an onion and mop the floor and sit down and walk, those kind of things. Now, when we're talking about any type of treatment, we have to talk about efficacy, or how well the treatment works. This is highly variable, how treatments work, but it's a little easier to get your head around if we use a concept called NNT, which stands for numbers needed to treat. Numbers needed to treat means, how many people do I have to treat with this treatment? Let's just say gabapentin, since we'll try to use it for most people with CRPS or other neuropathies. How many people do I have to treat with gabapentin before one person gets a 50% reduction in their pain? The number is 4. That means I have to treat 4 people before one person says thank you. The other 3 don't respond, or they respond poorly. That's why there's so much trial and error in pain management, because we're dealing with complex entities, and most people don't respond to the regular treatment. If I've got an infection, antibiotics always work, almost. It's not so in these complex neurological cases, especially when there's a psychological component. This applies to medications, physical therapy, interventional treatment, behavioral treatment. There's a limit to what we can do. There's a lot of trial and error, but that's what we do. Next, please. Next slide. Okay, so we're assuming we have a patient, we have a diagnosis, we have a treatment plan that they've gone through, they've had the benefits of as much treatment as we know how to offer them. Now somebody like me is called in to tie up the loose ends. So as a QME, one of the things I do is I assign an impairment rating. I have to use the AMA Guides 5th edition because that's what the legislature told me I must use. This book was printed in 2020. That was before the Budapest criteria even existed. But this is a book about impairment, not diagnosis. And I can still use this very old textbook to come up with an accurate impairment rating for my patients, especially because of Almaraz Guzman, if you've heard of that. I'm allowed to go to what they call all 4 corners of the guides, meaning I can use anything in this for an impairment rating as long as I can explain it well so that people understand it, especially judges and lawyers. So with that, let's go on to the next slide and we'll see the best way to handle CRPS. Now, on the beginning of this, I said that CRPS starts in the central nervous system, in the brain, and then a cascade of events happen after that. So chapter 13 is the central and peripheral nervous system, and this is the best place to handle most impairment ratings for CRPS. For one thing, there are 3 separate sections that allow me a lot of flexibility to kind of match up the patient to what's going on in his or her real life. It's non-dogmatic by and large, and I can choose whether the patient's impairment is more pain-related or function-related by using these 3 sections in chapter 13. So this is the place I'm going to go most often to start an impairment rating on a patient with CRPS. If this is not good enough, or it isn't accurate enough, or it doesn't describe what the patient's actually going through, then I'm free to go to other places in the guides and analogize. That's why we see fairly frequently, I think we see the hernia chapter being used for a lumbar spine injury. It's because the lifting restrictions are closest to what the patient is experiencing. Now, there are other chapters that I can use also. Let's go to the next slide. Chapter 16 is a problem. This is the upper extremities. The person that wrote the chapter on or part of CRPS in this chapter came up with their own diagnostic criteria that you have to use before you can get an impairment rating. I've never seen the diagnostic criteria that the doctor used who wrote this part. I've emailed him twice to ask him where it came from so that I could use it, and he never returned my emails. So the criteria in this chapter is a problem. First of all, because that criteria does not include the fact that there must be an injury, only pain. That means that any pain that the patient complains about is fair game to be diagnosed as CRPS in the upper extremities using this chapter. As it turns out, most cases of CRPS will be dismissed and the injury will be misdiagnosed, and the patient will be treated for non-industrial medical conditions or whatever they're left with. And an impairment may be given for a non-industrial medical condition like rheumatoid arthritis, for instance. So I cannot use this chapter because I can't stand up in a deposition and say it's accurate. Next slide, please. The other problem is to rate an impairment with this chapter, you have to use range of motion. You have to measure the range of motion 3 times in every joint. Now, suppose I had CRPS in my hand and arm, which is common. To rate the impairment, I would have to measure the range of motion of this joint, and then go through every finger, my wrist, maybe my elbow, and my shoulder, 3 times each. That's really hard to do accurately in somebody that has no medical problems at all. In somebody with pain, it's impossible. Nobody's going to, in pain, especially CRPS, they don't want to move. You're never going to get much of a movement in this. So you're going to have a very high impairment rating just from that alone. And most of it is not going to be accurate. It's going to be a guess on the physician's part. So if you get an impairment rating based on chapter 16, I would look twice at it. I don't know what you can do about it, but I would be very suspicious of how they arose, how they got both their diagnosis and their impairment rating. And I can't use this chapter. So I'll go back to 13 or someplace else. Next slide, please. Okay, there's more. The lower extremities has a chapter on CRPS, but luckily they refer us straight back to chapter 13, the central nervous system, so that's not a problem. Chapter 18, CRPS is a chronic pain condition. You can use chapter 18 to give a pain rating, but it's going to be 3%. Now that could explain an impairment for a very, very, very mild case of pain, but not for most CRPS impairment ratings. The other thing is, chapter 18 says, when other conditions are adequately rated in other chapters, use those. Mostly back to chapter 13. So anyway, that covers the impairment ratings. Next, please, Janice. Next, we're back to future medical care. There's nothing special here. This is the same stuff we talked about in the slides before. Medications as they are proven to be helpful. Physical therapy for flare-ups, but most importantly, people with CRPS, especially the lower extremities, start to have gait problems. They don't walk right. And they start to use canes on their own a lot of time, and they don't know how to use them correctly. And between walking funny and using a cane, they can start getting pain in the back and the hips that may lead to problems just with ambulation, but also compensable consequences that are purely due to the fact that they didn't have a thorough training in how to walk with these problems and how to use a cane or other ambulatory device. Interventional treatments, these things are going to be, unless we go as far as talking about spinal cord stimulators and intrathecal pumps, which are a separate category of things, are going to be flare-ups in those patients that have sympathetic pain. We call it sympathetically maintained pain. And I'm double using this picture of the woman's foot because I kind of lied at the beginning. This actually is a woman with CRPS, but between the left-handed picture and the right-handed picture, she had a lumbar sympathetic block. And that's what happened to her a few weeks after the block on the right side. It can be remarkable. So if somebody has sympathetically maintained pain and they respond to these blocks, that should be part of future medical care. and they should get them for flare-ups because it's a lifesaver to these people. It's not a cure, but a lot of times these can last for months and months, and that makes a big difference in people's lives. Next, please. So we didn't talk about how bad CRPS can really be, but it can be bad. This drawing here was from a woman who has CRPS, and it was how she expressed her life. Bad CRPS stays bad. It's not going to get better. Okay, as I said before, it might fade over time, but it's decades of slow improvements, decades. These people are bombarded by their environment. Light touch is excruciating. During the Civil War, when this was first, this syndrome was first described in great detail, these are soldiers that had nerve injuries that ended up with CRPS. And Dr. Mitchell, who is the surgeon that was describing all this, talked about how even a light breeze would send these soldiers into crying fits. When they were drumming on the base, that would cause pain. Just minor things would cause excruciating pain to these patients when it's really bad. Now, there is no cure for this. The body tries to mend itself and maybe it'll fade a bit, but I've seen patients just get worse and worse until I don't see them again. I don't know if they moved along, killed themselves, or what. But if it's really bad, it's really bad. Next slide. So my final thoughts for us today is the only way to really diagnose this is with the Budapest criteria. An improper diagnosis can result in delays in treatment, treating the wrong problems, getting the wrong impairment ratings, and keeping the patient in the system way longer than they have to be. And the most accurate impairment ratings I find come from chapter 13. Next slide. That's it. I'm happy to take any types of questions.
Well, Doctor, I don't see any questions at this time. We'll give everybody just a minute to see if they have a question they'd like to put in. But in the meanwhile, Janice and Wendy, if you guys would like to pop up on screen. I'd like to thank you both very, very much for joining Doctor in this really interesting topic. It is very fascinating to hear how long ago this has been diagnosed and what the procedures are. Wendy, do you have something you'd like to add?
Yes, there is a question. Does this usually result in 100% PD?
My experience with the end results of permanent disability are limited. But I have, from what I understand, talking with attorneys and the whole system is, I can't get to 100% with a standard impairment rating for CRPS. I believe 60% is as high as it'll go normally. But frequently there's a psychologist involved, a psychologic QME also. So I would say that there's probably going to be two different ratings, one from a psychologic point of view and one from my point of view as a physician here. But I don't know exactly how many, if any, end up at 100%.
Okay. The next question is, when you mentioned the block helping for a month, is there a longer, more permanent remedy?
What I think I said was it can last months. And it's going to depend on the person. If it only lasts, if I do a sympathetic block on somebody and they said it was really great for a week and then it all came back, that's not a success. So I would not say that's part of the treatment plan for the future. If they get 2 or 3 months worth and they were using less medications and they were more active and they were happier. In other words, they were having a good life, a better life, then that's a treatment plan for me. There is no permanent cure for these things. A next step, if somebody met criteria, might be to think about a spinal cord stimulator, which can override some of the pain. That's a whole different procedure that involves a trial of about a week with a temporary stimulator. And if they get really good results, a permanent one can be implanted. And for the right patient, that can be life-changing. But nothing that you can rely on any treatment.
And then we have one last question. Are you noticing a rise in the CRPS diagnosis? We are seeing a large amount of treating doctors providing this diagnosis, and then the QME and AME does not find CRPS.
That is consistent with what I understand and I'm familiar with. If you don't know how to diagnose it and you haven't seen a lot of it, if you get a weird case, you're going to call it CRPS. Most people don't understand the Budapest criteria. They don't use it because they don't have the training and the experience with these patients. So when somebody comes up with a couple of those criteria, they're going to say, maybe it's CRPS. And that's common. I've seen that all my career. That's kind of the place. I just want this person out of my clinic. Let's send them that way. They have a couple of, but to be accurate, it's easy to go through that diagnostic criteria like I showed and come up with an accurate diagnosis. Somebody just has to do it.
Well, thank you. That's all the questions that we have.
And again, Dr. Janice, Wendy, thank you so much for joining me today. And for our audience, I just want to remind you what we have coming up. Tomorrow we have something called Teicheira Unity in the morning, and then we're going to be deconstructing some psych records in the afternoon at 1:30. We have a bonus. We actually have a baker's dozen of classes, and then one of the new ones is going to be on structured settlements for workers' comp. Are they still relevant? And here's one that I really like. Even if you have not a lot of motor vehicle accidents and workers' comp, this is really a fascinating one that it would be interesting to even to learn about your own vehicles. This is on electronic data that comes from regular types of cars and trucks all the way up to heavy equipment that's used by a lot of our employers. And that is going to be coming up on Wednesday. So if you haven't signed up for those, please go to the Macro Pro website. All of the webinars are going to be on the right-hand side. Find it, click it, and register. Until tomorrow, we will see you later. Thank you for joining us. And Dr. and Janice, thank you for being the very first webinar of our special 12 CEUs of Christmas. Bye-bye now.
Thank you.
Thank you.